start by introducing Dr. Chapman. It feels kind of strange having to introduce Dr. Chapman yet again. He's been involved with Alpha-1 Canada a lot longer than I have as the chairman of our medical advisory board. He's also professor of medicine at the U of T, and I think it's fair to say that he's an internationally respected researcher in a lot of different things, asthma and airway diseases, but for our purposes, especially Antitrypsin Deficiency. And Dr. Chapman also runs the Canadian registry for Alpha-1 Antitrypsin Deficiency, which many of you may in fact be registered with. Dr. Chapman is going to talk to us about treatment for Alpha-1 and what the latest research tells us. And Dr. Chapman is certainly well positioned to speak on that topic since he's done most of the latest research on. So without further ado, I want to give people as much time as possible. Dr. Chapman, the floor is yours.
All right. Well, good evening, and it's good to chat with people. Right now it seems to be a one-way conversation, but I gather from Jim that after I'm finished mumbling over the next few minutes, we'll have time for Q&A. So I'll try to cover some of the highlights in Alpha-1 research over the last year or so. And forgive me if you've heard some of this. Maybe I'll put it into a context for you and offer a personal thought or reflection on it. I should pause at the very beginning and say, as Jim just said, I've been very much involved in some of this research, and that means that I know a lot of the behind-the-scenes story of the current research. I know about all of the analyses, and I know about plans for publication and what the odds are and where it will go and it won't go. I won't actually be able to talk about some of that behind-the-scenes stuff. I'm not trying to keep anything from you, but if we're planning on publishing some of our latest research in good, strong journals that everybody's going to pay attention to, we can't let out the news ahead of time. We can't scoop ourselves. So we'll be talking tonight in the next few minutes about things that are in the public domain, things that have appeared at major medical meetings and have been discussed there. I won't, or at least I shouldn't be letting slip anything that research scientists have not already heard about in a proper place. Again, the goal is that when the story is fully published, everybody pays attention. If we scoop ourselves, we won't be published prominently, nobody will pay attention, and the news that you want arising from the research won't get distributed properly. So, I thought we might talk about 3 or 4 general areas of research or development in Alpha-1. The first one would be the RAPID trial. That was a trial sponsored by CSL Behring to look at augmentation therapy, intravenous infusions of Alpha-1, and in particular their brand of Alpha-1 Zemera. It's appeared in abstract form at major meetings. Some of the analyses following the major analyses have appeared, so we can talk about that. There have been announcements about another trial done by the Israeli company Kamada. It's about their research with inhaled Alpha-1, and of course that makes it a very, very interesting story. What we have so far is very preliminary information. We don't even have a full analysis presented at a major medical meeting yet. I thought this might be a venue to talk a little bit about the Canadian Thoracic Society statement that appeared a couple of years ago, simply because it does say some important things about treatment, which is our subject tonight, and it says some important things about screening, where there have been a number of developments. And so the last thing I wanted to mention very briefly was some of the developments taking place in diagnostics of Alpha-1, in particular, rapid diagnostics of Alpha-1. So let's start with the RAPID trial. As I mentioned, the RAPID trial was sponsored by CSL Behring, and it was done at the request of the FDA, the Food and Drug Administration, and it was a trial that many people have been waiting for because, as I think you may know, we have not had a definitive trial in scientific terms showing the benefit of Alpha-1 antitrypsin augmentation therapy. Now, that may seem strange given that the therapy's been around for 25 years, but as you know, Alpha-1's a rare disease. As you also know, emphysema takes a long time to appear and progress. And in the early days, as people looked at clinical trials of augmentation therapy, they said, well, the usual approach is to give the treatment or to give placebo and to follow and measure an outcome. And the outcome that lung doctors are familiar with is the breathing measurement spirometry, or specifically the measurement parameter FEV1. And as people sat down with pen and paper and calculator to decide how to run the trial, they realized that because Alpha-1 progresses slowly, that they would need to follow about 500 people on treatment, about 500 people on placebo, and they would have to do that over about a 5-year period. Now, it's a rare disease, and nobody, or no reasonable number of centers, had that many patients to study. And that completely overlooks the enormous cost and difficulty of doing a trial over a long period of time. So we've waited for a definitive trial, and what's made it possible is a different sort of measurement. The measurement is a measurement of lung density. As you know, the lung should be a dense sponge-like material where oxygen is exchanged for carbon dioxide. But what happens with emphysema is the dense sponge becomes a bit moth-eaten. It becomes less dense and is broken down. It's possible to do fancy X-rays, CT scans, and actually measure that change in density. Now, I say that as a non-X-ray specialist, as if it were an easy thing. In fact, it's been an area under development for about 20 years. It's very easy for a doctor to look at an X-ray and see that the lung looks very, we would say, lucent or dark, emphysematous, but it's very difficult to put a number to that and to quantify the changes precisely. Well, fast forward, in the last 5 or so years, last 10 or so years, we've become more and more confident in our lung density measurements. So, beginning in approximately 2007, CSL Behring began to recruit patients in a large number of centers around the world. So there were European centers, American centers, Canadian centers, we were one, Australian centers, recruiting patients who for 2 years would take once per week intravenous treatments. And the patients didn't know, we didn't know, whether they were receiving the real treatment, the Alpha-1, or placebo treatment. The study involving 180 patients, each treated for 2 years, in fact took 7 full years to complete. So cast your mind back to that hypothetical study of 1,000 patients for 5 years, and you realize that it's still going to be a pretty difficult study to do. Those are large numbers. But coming back to our 180 patients, the CT scan is such a sensitive measurement of density that it gave some pretty good answers. Now I'm going to pause and take one of those little detours, and I hope this is something you want to know or need to know, but it is confusing to a lot of people. When research scientists do a study, especially a big, important study that they want to give a clear answer, they will decide ahead of time how to analyze their data, how to analyze their information. And one of the odd things about the RAPID trial is that the CT scan density measurement was made twice at each sitting. It was made when people took a deep breath in, lung doctors would say total lung capacity, and it was also made at the end of a normal breath, and we would say functional residual capacity. The reason for the two measurements was to allow for a correction of lung volume, which changes over time. It was simply a way of calculating and sharpening up the answers that we wanted. But towards the end of the study, the negotiations with the FDA, remember them, they wanted the study, indicated that all of the information should be included in the final analysis. Now, in all of the other lung density studies, the only information that's been analyzed is the sharpest and best information, the full deep breath in TLC lung density measurement. But at the request of the FDA, both measurements were tossed in, and they were analyzed, and they become what scientists call the primary endpoint. So, bottom line, RAPID trial, it clearly showed that at the total lung capacity measurement, lung density was preserved, spared, in people who took augmentation therapy, as it fell in people who weren't taking augmentation therapy. So those of us who are familiar with the field and CT density measurements look at that and say, great, it was a clear and positive study. Unfortunately, the final analysis that involved both measurements muddy the waters a little bit, and the two measurements put together yield a result that is close, but not quite statistically significant. The preliminary results of the RAPID trial were reported a year ago. The paper is in negotiation, and it will appear in print someday soon, I trust, but the long lag probably says something about the muddiness of those endpoints. So if you have heard about the RAPID trial and wonder what's taking so long, it's this strange business at the end of how the information gets analyzed. I should go on and say another thing or two about the RAPID trial. In the RAPID trial, over 2 years, there were no clear changes in the usual breathing measurements. Now, that doesn't surprise us involved in the trial. We know that the CT scan measurement was chosen as a very sensitive measurement, one that would give us an answer over 2 years. And we also knew that the usual breathing measurements were unlikely to change in any important way. But all of that said, it sometimes confuses our colleagues who aren't familiar with the area. And doggone it, they still like to think about Alpha-1 as plain ordinary COPD, and they still want to see changes in spirometry, even though that's the very reason we were doing a study with fancy X-rays instead, because we know spirometry isn't good enough to give us the answer. Another interesting thing about the RAPID trial is that although it used just the one standard dosage of Alpha-1 treatment, which, in case you're interested, is 60 milligrams of Alpha-1 protein intravenously once per week per kilogram, so it's a weight-based dosage. Even though it used just one standard dosage, the resulting blood levels of Alpha-1 did vary a little bit from person to person. And the investigators have done an analysis, and it shows that people with higher serum levels had better protection, people with lower serum levels had less protection, and the result has made people think again about what the best dosage is. In other words, is 60 milligrams per kilogram enough? Should the dosage, in fact, be higher? And I mention that not to distract people or confuse people, but to introduce indirectly another trial that's underway now called the Sparta trial. It's one that's also being done at the request of the FDA. It's being sponsored by a different company, Grifols, the company, in fact, that distributes the augmentation therapy in Canada, Prolastin C. And it will look at 3 years of treatment with the standard dosage of Prolastin C, double the standard dosage of Prolastin C, and placebo. By the way, both of these trials, the RAPID trial and the Sparta trial, are aware that if people are going to give up some time and have x-rays and receive placebo, it would be good to reward them. So both trials have included active open-label treatment for the placebo-treated patients, or for all of the patients, at the end of the trial. So there is something in it for people who participate in the trial. I'll move on now to a different kind of trial and a different kind of treatment. That would be the Kamada-sponsored trial. And we know less about this one because it's just been completed, it's just been analyzed, and in fact the analysis is continuing. It's a large amount of information, a large amount of data, and so we're still getting answers from the Kamada trial. But very briefly, if you hadn't heard about it before, the Kamada trial involved people inhaling their Alpha-1 protein using a fancy nebulizer as opposed to receiving it intravenously. The hope has been that by inhaling it, it will make life easier for people. They won't have to go to a clinic or someplace to get poked with a needle. The hope has also been that by inhaling the protein directly into the lungs where it's most needed, the effect will be greater and allow us perhaps to use a little less protein, especially because it's going in daily. It sort of smooths out the rise and fall of protein level. We knew from preliminary studies that inhaling Alpha-1 was possible. We knew from some other company studies that occasionally there were difficulties with this, the possibility of mounting an immune reaction to the inhaled protein. But all that said, the Kamada trial went ahead comparing inhaled Alpha-1, inhaled placebo, and the goal of the trial, the end point of the trial, wasn't breathing function, it wasn't CT scan lung density, it was exacerbations, those flare-ups or chest colds that mean people need antibiotic and or prednisone, or perhaps need a visit to the emergency room, or for the worst exacerbations, the sort of thing that you can be hospitalized for. The Kamada folks have made 2 public announcements, press releases about their trial. That's because they're a publicly traded company, and publicly traded companies are meant to issue statements about substantial results, things that the stockholders need to know about. So we've got a funny sort of report from Kamada. It's a report for investors, not a report for scientists. The initial report was that the trial was negative, that there was no decrease in flare-ups, decrease in exacerbations in people inhaling the Alpha-1 protein. But just recently, about 2 weeks ago, Kamada had another press release, and they said, well, there is actually a difference if we look at people who were exacerbating or getting sick frequently before the trial. So in other words, the people who needed it most to prevent exacerbations were the ones who benefited. Now, this is a tricky sort of announcement to make. It sounds like good news, and it's certainly something we want to follow up on. The doubting Thomases of the world, or the conservative scientists, would say, well, we want to make sure that you're not data dredging, that you're not just running through all the analyses you can think of until you find something that looks good and reporting that. So, bottom line, we're waiting on the Kamada information to be presented at a scientific trial, a scientific meeting. The first is likely to be the American Thoracic Society meeting this May. We may be able to see the data before that in a publication, but my hunch is we're probably going to see a poster or a presentation in May at the American Thoracic Society meeting, and then we'll be able to judge for ourselves whether this was an important result or not. So inhaled Alpha-1 interesting, still alive, still of interest, but the trial was a muddy one. I said that I would say a word or two about the CTS statement. I'm not sure, but I think I might be the only person to be involved in one of these teleconferences who was also a co-author of the Canadian Thoracic Society statement on Alpha-1. I'll have to admit I'm a little bit cynical about these statements and guidelines, and I'm not completely happy with the way they're put together. Nonetheless, there were two goals of this most recent statement. One was to address the question of augmentation therapy. Is it something lung doctors should consider? And number two, who should be screened for alpha-1 antitrypsin? So to deal with the first subject, 25 years after alpha-1 therapy became licensed in Canada, the Canadian Thoracic Society finally said, well, yes, augmentation therapy should be considered in people with a deficiency of alpha-1 if their FEV1 is below 80% of predicted, all the way down to, I believe it was 25% of predicted. They said that they found there was merit or benefit based on CT scan studies. There have been a couple of preliminary studies before RAPID. And they also found evidence in terms of reduced mortality from some of the older observational studies. So for the Canadian Thoracic Society, this was the first strongly positive statement, and I would say that I'm seeing renewed interest in alpha-1 amongst lung specialists and an increased awareness of augmentation therapy. Now, I mean awareness. A lot of doctors are still very unfamiliar with the alpha-1 field, but at least now they're thinking about it and making appropriate referrals. The second part of the Canadian Thoracic Society statement was about diagnostics, whom should we screen, and the bottom line was we should screen everybody with COPD, garden variety emphysema, or obstructive lung disease, just to make sure that they're not an alpha-1 patient. It's not as clearly said, but patients who have an abnormal lung function after treatment, when they're thought to have asthma, may in fact be people with alpha-1, and that's also a place to screen. I wanted to highlight that screening because I'm seeing more abnormal alpha-1 results referred to my clinic, so doctors are certainly taking this advice. They are looking at their practices. They are finding patients. Most commonly, they're finding carriers, people with slightly reduced levels, and we're not very concerned about carriers. Carriers do very, very well with little risk of liver or lung disease. But they are finding severely deficient or homozygous patients as well. The field of diagnostics and screening is heating up around the world, and I know that from speaking with several of the companies involved in the alpha-1 field, they are looking at ways to make the diagnosis easier for general practitioners and for lung specialists. One of the interesting developments has been by the Grifols company again. They've produced something that they've referred to in various terms. One of the terms I've heard is an alpha kit, but it's essentially an in-office diagnostic. So think of something that looks a bit like a pregnancy tester that you'd use at home, but with a spot of blood in a patient, a doctor can find out whether that patient has an abnormal alpha-1 gene. Now, that particular kind of screening that can be done in the office will pick up both carriers and fully deficient patients. So, in other words, follow-up testing still has to be done. But it's a very, very interesting point-of-care test, and it was initially introduced in a preliminary way in Germany, and it's no longer being used there now, pending some modifications, but it should likely be introduced in the near future, and work will carry on. So diagnostics are sharpening up. There may be new ways to get the diagnosis made. I imagine there are people on the line who had some struggle getting the appropriate blood test done. So with that, I've gone through the rapid trial, the Kamado results, BTS statement, a word about some of the emerging diagnostics. Maybe I'll pause there, Jim, for Q&A and see if we've covered some of the things that people wanted to hear.
Oh, thank you very much. That's great.
Jim,
if
I
anybody has
interrupt
any...
1 second?
Of course.
Just to ask people to mute their phones, please. If you could tell them how to do that, Jim.
Yes, I'm sorry. I said I'd do that at the beginning, and I didn't. It's *6*. And then to unmute, it's just *6* again. Oh, a lot of people did it.
Yes. And I apologize, Dr. Chapman. We should have said that at the beginning, and I'm sorry for some of the distractions from the noise. I apologize.
Not at all.
Okay, Jim, go ahead.
Yeah, so if anyone has any questions, just speak up. And if too many people speak up, we'll try to manage it.
Hi, can I ask a question?
Certainly.
Of course.
Well, what I'm interested in, you've done a couple of studies of the augmentation therapy. Have there been any trials or tests or experimentation with the liver to find out why the liver is not releasing the proteinase, the Alpha-1?
I think we know why it isn't. That is, the Alpha-1 problem in the liver is a conformational disease, meaning, as I understand it, this long string of protein, this long chemical, is meant to fold up in a very elaborate way so that it can then be released from the liver cell into the bloodstream. And because of the small changes in the makeup of the Z protein, the abnormal protein, it doesn't fold properly. It sticks out. It looks like my kind of Christmas wrapping. And these long proteins stick to one another, polymerize is the technical term, and build up in the liver. I think what we don't know for sure is why some people get the liver disease and why some people don't. And I'll offer the standard sort of doctor response, but it's certainly true. It probably has a lot to do with your remaining genetics. If you have some other bad liver factors going on, then you're probably going to get liver disease along with your alpha. But if your other liver factors are okay, then you won't get liver disease. Now, in terms of treatment, I suppose right now, other than general supportive care from the liver, not doing bad things to your liver, we don't have specific treatments short of liver transplantation. But there is a lot of interest in finding small molecules that would bind to the abnormal protein and would help it to bend and fold up in the appropriate way, and in that way allow it to be excreted from the liver cell so it wouldn't build up, wouldn't do the damage to the liver cell. Right. I have not seen a strong, successful small molecule candidate yet, but there are groups working on that actively.
Thank you, Dr. Chapman.
Dr. Chapman, when do you expect the rapid trial information to be made public?
I expect it will get out in a full paper sometime in 2014. So by the end of the year. That's not a promise, by the way, or a statement of fact. That's just my expectation. Take it for what it's worth.
Thank you.
Dr. Chapman, I have a question about the Sparta trial. Has that already commenced? What stage of the trial is it at?
The trial has begun. I can't tell you off the top of my head which sites are active. We are active as of tomorrow, I think. The site in Halifax is active. They've been active for a couple of weeks. And those are the two Canadian sites. So the trial is recruiting now, and will be recruiting probably for the next couple of years, would be my guess.
And so are you looking for patients, I would assume?
Absolutely. I don't want to come on here and start recruiting patients, but yes, if people are interested, do get in touch. You can speak to our research staff, and they'll give you all of the details that I'll forget, and they will be happy to send you the consent form so that you can take it, read it at your leisure, share it with your family members, think of all the questions you've got, and ask those questions.
And would this still be Jane, Dr. Chapman?
Yes, Jane Duke is going to be the key person running this trial for me. So Jane now has a lot of experience with our Alpha-1 trials. She was there for the Roche trial of retinoid therapy. She masterminded the RAPID trial for us, and she will be doing the Sparta trial.
Wonderful, thank you. Do we have some other questions, please?
Yeah, I have another question. What's the status of the synthesized rDNA form of Alpha-1 protein?
It's still in the development stages. Are you talking about the mRNA gene replacement therapy or the recombinant Alpha-1?
Recombinant Alpha-1.
There's a bit of a hiatus for recombinant Alpha-1. Just to back up a little bit, it's possible to put Alpha-1 making genes into bacterial cells or yeast cells and create the right conditions in a giant flask or brewer's vat and get those cells making Alpha-1 for you. The problem is it's not fully humanized Alpha-1 in the sense that the next step, adding little sugar molecules or glycosylation, doesn't happen. So if you take that recombinant or genetically produced Alpha-1, you don't have much success injecting it. It is cleared from the bloodstream very, very rapidly. Now that leads to one of the earlier inhalation experiments where some recombinant Alpha-1 was inhaled. The experiment was abandoned when people started to develop some immune responses to the inhaled Alpha-1. So right now I'm not aware of a recombinant Alpha-1 trial that's getting close to the clinical research stage.
Thank you.
Doctor, is there a consensus on what is the protective level? I'm taking the augmentation therapy now weekly, and I was like 0.20 without it, and I can get up to 0.7 or 0.8 with it.
And I'll add the standard proviso. I can't give medical advice over the phone like this, but let's take that as a general question. I think it's a great one. The goal of Alpha-1 treatment for a while has been to keep blood levels not in the normal range, but in a range that was regarded as protective. And the level that was regarded as protective was a level of about 0.55 to 0.6, given in the units grams per liter or milligrams per deciliter. And I think those are the units you're using.
Absolutely.
So we want to make sure that the levels don't drop below that, and so we measure them at trough. In other words, just before you're due for your next infusion, when your blood levels are going to be at their very lowest, we draw the sample.
Right.
And sounds like you're receiving the therapy the way it was designed. It sounds as though the level you quoted, if it was measured at trough, is above where we want it. Great. But your general question was, so is there agreement on the levels? And as it turns out, there isn't. These were calculations or assumptions that were made 25 to 30 years ago about augmentation therapy. And it's interesting, if you ask some of the people who were around at the time or know people who were around at the time, you hear different stories. You hear that the trough level that we're aiming at, the lower limit that we're aiming at, was based on the lower levels we see in carriers, with the belief that carriers don't get into trouble. Another story is that we are basing this on the SZ patients, patients who were not thought at the time to get into trouble. But we now know that some MZ patients do have a bit of difficulty. We know that some SZ patients do have a bit of difficulty, and we're now starting to wonder about that level. So, back to the RAPID trial, if that's what made you ask the question.
It was.
We've seen that in the range of blood levels we achieved, there was actually a range of protectiveness. And it was we'd say linear, it was a line. In other words, we never did see the end of the protection or the plateauing of the protection, and it made us wonder if we could give a little more and get even more protection. That's why the Sparta trial is being done. So I guess in terms of, and I guess I should say, it depends on who you're talking to and what the context is. So if you're talking about getting treatment from your local lung doctor and he's willing to write a prescription for augmentation therapy and your insurer is prepared to pay for it, there is a standard and accepted dosage. And not much debate about that clinically or with Health Canada. But amongst the people who are involved in the field, we do have a lot of interest in exploring doses, and we're going to be looking with great interest at the outcome of the Sparta trial in a few years to see if that tells us something about higher doses being more protective. I guess the only practical thing I'll say now is when I sit there with my calculator and calculate out 60 times however many kilograms it is, I tend to round up on the dosage. How's that?
That's excellent. Thank you very much.
All right.
Do we have other questions, please? Oh, you're doing a great job, Dr.
If no one else does, I do. I was just with respect to the RAPID trial, Dr. Chapman. It's certainly my understanding from dealing with a number of provincial payers that there's a debate on the appropriateness of CT lung scan density as an endpoint in the first place, and that they're reluctant to give much weight to any studies that show efficacy based on CT lung scan density. And is that debate settled sort of in the medical community? Because it certainly isn't among payers.
No and no is the answer. And it's a great question, and perhaps I should have raised this directly. First of all, the payers tend to use any excuse they can, so there's always that factor. But in fairness, I will tell you that for years, doctors have been aware that if they did a CT scan, they could find a patch of emphysema in a patient who was otherwise quite well and had normal spirometry. And so we've become accustomed to saying, well, we're not going to treat people based on their CT scans. But now we've come back to Alpha-1. First of all, these studies are not based on a vague appearance of a little patch of emphysema here or there. It's a precisely quantified lung density measurement. And we know that it's probably the most important measurement in Alpha-1 because the whole abnormality is the loss of alveoli, the loss of lung structure. And the CT scan density measurement is measuring that structure and can precisely measure the loss. So there are studies that have been published showing that in Alpha-1, CT density is actually a better predictor of outcome than anything else you could do. It's better than FEV1. It is, in effect, a more direct measurement of what the problem is. So what you're in the middle of is something of a paradigm shift where doctors and perhaps payers have been accustomed to saying, well, look, the measurement we really know is lung function, is spirometry, and we don't want to place too much emphasis on these CT scans. And they've really got to be helped to understand how different this setting is and why we make the argument for CT scans. I will add, and I can't say too much, but I know that in the analysis of the RAPID trial, there's been an attempt to look at loss of lung density and what that means to outcome. And it's a very interesting story, and I think it will help our colleagues and to some extent our payers understand the importance of this measurement. Last comment, and along these lines of doctors and do they believe it, I know I struggled with some of my colleagues as we wrote the CTS statement, and a lot of them struggled with the CT scan endpoint measurement. In the end, they accepted it, but it was a challenge. But the next problem was many of them then felt that in order to use augmentation therapy, they would need to have access to the CT scan lung density measurements. And that's not the intent of the trial. We may get there one of these days. We still base the prescription of Alpha-1 protein on serum levels and lung function measurements. The CT scan measurement is what scientists call a proof of concept. We showed the phenomenon. It's very, very clear, but it doesn't mean that you have to go out there and measure it in every patient. That's why we did the trial, so you wouldn't have to.
Thank you.
So, if I could add one more question on the RAPID trial. Obviously, I'm very interested in reading this thing, but I may have misheard you. But did you say that we've always been told that augmentation therapy slows the progression of the disease. It doesn't arrest it, and it certainly doesn't cure it. I thought I heard you say that there was, in a number of patients, there was no change in density. So there was, or was it just too short a time for? Because I mean, we all lose lung function as we age, right? Anyway, right?
Yes, if I said that, I misspoke, Jim.
Okay.
In both groups, there was a loss of lung density, but it was slower in the group receiving the augmentation therapy.
Yeah. Which is what we'd expect.
Yeah.
Okay. Any other questions?
Well, somebody called me about a recent study that was released about lung cell epithelial or lung epithelial cells, and the idea that I'm just trying to read it now. That polymers of Z alpha-1 antitrypsin form in bronchial epithelial cells as well, suggesting that these cells may be involved in the pathogenesis of lung emphysema and bronchial epithelial cell dysfunction. Are you familiar with that study and what it might mean in terms of alpha-1 patients?
It's one of those conceptual studies, that is, to try and understand the pathophysiology of the disease. And the suggestion is that although most alpha-1 protein is made in the liver, other cells can produce it as well. And the other cells include the basic structural cell of the lung, the epithelial cell. And it's possible that there are polymers, those aggregates of alpha protein that are somewhat irritating, actually appearing directly in the epithelial cell, not delivered via the bloodstream. So an interesting study. I don't think anybody had actually measured that before. Again, it tells us a bit more about where the injury comes from. It doesn't inform our therapy directly right now.
Right. Yeah. Are there any other questions? We don't get this kind of access to Dr. Chapman very often, so this may be the last chance in a long time to ask him some questions. So I also like to point out that we have a record attendance at this call versus all the other ones. So I know there's a lot of people out there who are being quiet. So if you have a question, please speak up and ask it. All right. Well,
I don't have actually just one thing. It's not a question on the direct research, but Dr. Chapman, maybe you could just tell us a little bit about the Canadian Research Registry and who that's for and what it might involve as a patient.
Sure. Gosh, I could have planted that question. It's near and dear to my heart. The Alpha-1 registry is part of a network of registries, and it's the way we're going to make progress with this rare disease. You heard me say early in the call that we've had this protein around as a treatment for 25 years and haven't been able to do a definitive trial for a few reasons, but largely because this is a rare disease. So as compared to a diabetes treatment, it's hard to gather up a few thousand patients and do a study in quick order. And unlike an asthma treatment, a standard COPD treatment can't do those sorts of studies very easily. The way studies become possible is if we gather up the names and contact information of people who have the disorder. That's what registries are for. Now, that's partly what registries are for. The Canadian Alpha-1 Antitrypsin Registry is maintained at the University Health Network. It's maintained the way research information is maintained, that is under strict guidelines of confidentiality. Your information is safe, and is reviewed both initially when we applied to open up the registry, and it's applied every time we want to make a change to it, and it's reviewed annually as well. The registry keeps some basic information. Who are you? Where are you? What's your Alpha-1 type? And some questions about your lung treatment, your lung numbers, your liver numbers, and other general information. We've learned a lot about the natural history of Alpha-1, so we published a paper about augmentation therapy a while ago. Some of the information for that paper came from the Canadian registry, and it showed that lung function tended to be preserved by augmentation therapy. It's a study called a meta-analysis. We published it a few years ago, and because it's a blend of several studies, it's not the sort of definitive trial we were after, but a lot of people paid attention, and it was a step forward. The registry has allowed us to get in touch with people and ask if they wanted to try out treatment with something called a retinoid, which was a study we completed with others and published. Unfortunately, the treatment wasn't effective, but it was a valiant effort. We've had patients in the RAPID trial that we've been discussing tonight, and we helped to recruit patients from across Canada to be studied at 3 different Canadian sites. And we will let people know who are in our registry about the Sparta trial if they don't hear about it in some other way. If you're signed up to something named Alpha, you might want to look and see if it's the Alpha-1 registry. Those are the folks who would ask you to sign a consent form and would ask you to forward some medical information once a year. If you don't belong to the thing called a registry, you might consider it, because that's the way you can give back to the science of this disease and help us to make progress fighting the disease, or for that matter, discussing things knowledgeably with the payers. I'll add, there wouldn't be an Alpha-1 Canada and a website and this teleconference if there hadn't been a registry first. We didn't hand over our list of names to Alpha-1 Canada, but we took invitations from Alpha-1 Canada and sent them out to registry participants so that people knew that there was a patient group starting up. And it was actually something that had been attempted 2 or 3 times before it actually stuck, but it looks as though Alpha-1 Canada is here to stay, and that's another sort of registry initiative. So by all means, Google Canadian Alpha-1 Registry or look for the link on the Alpha-1 Canada website. I hope it's still there. And navigate to us if you haven't been there before, and let us know you're out there. We will at least keep you abreast of the latest research and let you know if it may be something you would like to be involved in.
Thank you.
Yeah, it's Jim again. I would expect that a lot of people get us and the registry mixed up, and they think because they're registered with one, they're registered with the other. But I would think that most people on this call are registered with us for sure, because they got to notice that this event was happening. But I would strongly encourage people to make sure that they're registered with the registry as well. As Dr. Chapman, you're not agreeing to be a test subject. What you're agreeing to is being informed when there is a trial happening, and then you have the ability to apply, to be part of that trial. And of course, a lot of patients have benefited and are benefiting right now. For example, with this rapid trial, there will be people who currently don't have any insurance or provincial coverage for augmentation therapy, who, if they take part in the trial, not only will they have access to the therapy during the trial, I suppose, except for the third of the people that are on placebo, but the company has agreed to continue the treatment for you, and that's as people know, a huge benefit, because that treatment is upwards of $100,000 a year. So there's not only the altruistic benefits of being involved in research and helping advance the field, but there can also be some significant benefits for patients to be involved in research. Okay, well, if there are no more questions, I'm going to thank Dr. Chapman on behalf of all of us and all of you, and thank you very much for attending. Don't forget, we have another call-in like this with Dr. Jeff Teckman, and I believe that, I know that there's a trial going on in the States, and I believe they're accepting patients of a liver treatment. It's an already existing drug. I think it was for epilepsy, but they found that it seems to supercharge the autophagy process, which is the process in your body that tries to get rid of that mutant Alpha-1 in your liver cells. So I'm pretty sure that Dr. Chapman is well informed on that trial as well, and as well as all kinds of other things. So if Dr. Chapman's the guy, and we certainly think he is in terms of lung disease, Dr. Teckman is probably the guy in terms of liver disease. So I would encourage you to take part in that telecall as well on September 29th. I think it was in the same email and we'll of course send out more notices when it gets closer. So again, thank you very much, Dr. Chapman, and thank you everyone for attending.
Before everyone signs off, before you sign off, please, we'd like to ask you to let us know some of the topics that you would be interested in hearing. If you have a physician, if you have a respiratory technician that you like, that you think would be a good guest speaker, by all means, or any topic that we could research for you, please let us know. Email Jim, and we would be happy to continue these teleconferences and get you more information.